Good evening and welcome to this broadcast where we will discuss the drug Trodelvy, a new treatment option for patients with inoperable or metastatic triple-negative breast cancer. My name is Hans Andersen and I'm the editor of HealthTalk, and it's a pleasure to host this broadcast. I also will encourage you to ask questions to Fredrik Marmé as we go along. I can just explain it to you quickly. You do this by moving the mouse over the screen, then an Ask a Question button will pop up. Then you just click the button, write your question, so it's pretty straightforward. So Silje and I myself will ask the question to Fredrik after his presentation. So now it's time to introduce you, Silje Songemøller, doctor from Østfold Hospital. Welcome.
Thank you for the invitation. These are exciting times for us, for all of us who are involved in breast cancer treatment. And I must say that keeping up with all the knowledge, the new ways, the new methods and how to apply these and use these things can be really hard. So today we're focusing on sacituzumab govitecan, or SG for short, because this is really a tongue twister, known as Trodelvy. And Trodelvy has obtained EMA approval for both triple-negative and hormone receptor-positive metastatic breast cancer, but the Norwegian Beslutningsforum is still lingering, and the approval for HR-positive patients is still pending, whereas it is approved for the triple-negative setting. So, to help us get to know SG better, we're fortunate to have Professor Fredrik Marmé from the University of Heidelberg in Germany with us today. And he's joining us digitally this evening. Welcome, Professor Marmé.
Thank you so much for the kind invitation. As you said, my name is Fredrik Marmé. You nicely pronounced that. That's also not as easy because it's a French name. And I'm a gynecologic oncologist at the medical faculty in Mannheim, which is a larger city actually than Heidelberg and just 20 kilometers off. And the faculty does actually belong to the University of Heidelberg, where I've been working the 20 years before. So I joined the medical faculty here in Mannheim 5 years ago. You might wonder why there is a gynecologist telling you about how to treat breast cancer. This is some historic specialty or specialty that has evolved in Germany like that, because people started the surgical treatment and were then on the forefront also of developing the neoadjuvant strategy. So people that you might remember or still know, like Gunther von Minkwitz, or today Sibylle Leubel, Nadja Habeck, Peter Fasching, whom you might have seen at some of the great international conferences. They're all gynecologists and you might not even know. So one of the tasks that I have for this evening is that you will have forgotten by the end of the day, because once I get asked gynecologic questions in my daily practice, I don't have a clue. So I don't view myself as a gynecologist anymore. That's a long time ago. But it sometimes does also help to have some surgical training and know what surgery in the axilla and the breast, etc., actually means when you are treating patients with early breast cancer, especially in the neoadjuvant setting. So the title is centered about the treatment of triple-negative breast cancer with sacituzumab govitecan, and indeed that's a tongue twister. Last year I was presenting a mini oral at ESMO in Paris, and I just had to try it 3 times and then I gave up. And so I tried to stick to the SG because that's a lot easier. These are my potential conflicts of interest, but I want really to start showing you what triple-negative breast cancer is. And that's obviously data from a French registry between the years 2008 and 2016. So what does that mean? That's the mostly pre-CDK4/6 era. That's also the pre-TDXD era. And it's also the pre-PARP inhibitor era. And it's also the pre-IO era in triple-negative breast cancer. So that's maybe just, one step back in the ways that we treat, but still you see that the overall survival, the median for triple-negative breast cancer, is tremendously worse compared to to its hormone receptor positive or HER2 positive counterparts. So if you look at that, it's 14.8 months. If you look at the control arm in the Keynote 355, it's 16 months. So for those just receiving chemotherapy in first line without having a chance of receiving immunotherapy, it hasn't really changed a lot. And I didn't mention that, but it's also the pre-third generation ADC era for triple negative breast cancer. Just very briefly, and I think this is actually an excellent guideline, which has been converted into a living guideline. So that's the ESMO living guideline for metastatic triple negative breast cancer. You do have to look at the webpage of ESMO and click yourself through to this living updates. And what I think is very important and useful, it doesn't just give you some instructions, it does also give you the reference to the ESMO magnitude of clinical benefit scale, which I put up on the right-hand corner. And you see those treatments that are really worth giving are those which have a 4 or a 5 in the non-curative setting. And they're usually either linked to a substantial overall survival benefit or an improvement in quality of life and less toxicities. So if you look at the first-line treatment, I think this is quite clear to everybody. We have to define certain biomarkers. We should know the PD-L1 status in the triple-negative metastatic breast cancers. And for patients who are PD-L1 positive, there is a clear recommendation to give immunotherapy with pembrolizumab in that setting, having an MCBS of 4. The data for Atezo is more contradictory and not quite as clear. So that there is immunotherapy in those who are PD-L1 positive combined with chemo. For those who have a germline BRCA mutation, there's several options which are worthwhile considering. One of them obviously are the PARP inhibitors, which also have MCBS scale of 4, mostly not because they really achieve overall survival benefit, but because they are, in comparison to chemotherapy, better for your quality of life. They haven't been compared to the other option that is put up there, which is basically platinum-based chemotherapy, which are preferred over taxanes based on Andrew Tatt's TNT study. They don't have an MCBS grade because that was actually linked to the approval for certain subtypes of breast cancer. And for all the rest, so those who are biomarker negative, PD-L1 negative, germline BRCA wild type, there is just chemotherapy in first line. So preferred taxane or anthracyclines as monotherapy, and in those patients who have an imminent organ failure, even anthracycline and taxane-based combinations, something we did quite frequently in the early years of this century. And alternatively, I don't know if this is actually approved in Norway. It is approved in Germany. We could give taxane bevacizumab or capecitabine bevacizumab combinations, which in these cases are actually quite good. But when we go to second line, we move to the topic of antibody-drug conjugates. And this is actually something that has a longer history in breast cancer. And trastuzumab TDM1 was the first ADC which was approved for a solid tumor. There's been one ADC approved 13 years before that, which was later taken from the market for AML. And when I got to know the first ADC, namely TDM1, I thought this is quite simple. That's just an antibody that's got some chemo linked to it. It's taken up into the cell, and then it's going to do its job. And it did. We know the data from the Amelia study, and it led to an improvement in overall survival. But what we've really learned over the last couple of years is that these compounds are far more complex. This is just giving you an idea of the 4 components which are crucial for for the characteristics of these ADCs. One of them obviously is the tumor antigen. And what we want is a high and homogeneous expression in the tumor, where with the next generation ADCs, we can overcome some heterogeneity, which is good, and we'll see that in the clinic and also in preclinical models. This is still something that we aim for when we select tumor antigens as targets for ADC. And of importance, these targets don't have to be tumor drivers. We don't know that, for example, for TROP2, which is the target for SG. We principally know that HER2 is a tumor driver, but we're targeting this in a HER2-low population nowadays, where it's not a tumor driver. So that's not a prerequisite, but on the other hand, it can help. So if you have a tumor which is dependent on HER2, for example, it's far more difficult to really develop resistance mechanisms by downregulating the target in that case. That's not so much true for the HER2 low situation or the TROP2 situation where the cell is not dependent. Another feature which we've learned is mutations in these receptors like EGFR or HER2. HER2 in non-small cell lung cancer, for example, works very well, not based on expression, but rather on the activating mutation. And it seems to be also true that the mutation helps the internalization of the ADC. So you see how complex even the tumor antigen as a target can be, and what aspects are of importance there. Obviously, you need to have good features for the antibody. It needs to have a high affinity, specificity. It has to be efficiently internalized with reduced immunogenicity, and it should still elicit some antibody-dependent cytotoxicity. And then there's the payload. Today, we have mainly tubulin-targeted agents and topoisomerase 1 inhibitors as payloads, which is in some ways a pity, especially if we come to the question of sequencing these ADCs, because we don't have a lot of choices between changing the payload and the target. We have cell-permeable payloads today. This enables a drug to also have a bystander effect. Someone called that like it's like passive smoking. So actually, you're not smoking yourself, but the cell next to the cell that is actually targeted with the ADC and does not express high levels of the antigen is still being affected by the payload that is released from the cell, or in some circumstances also already split from the antibody when the ADC is bound to the receptor on the cell surface. For example, if there is a low pH in the tumor environment, so there is lysis of that payload. Then there's different forms of linkers. They're very important for pharmacokinetics. They should be stable in the bloodstream, so to minimize the systemic toxicities, but should still be efficiently released. And basically, we distinguish between cleavable linkers. That's what the modern ADCs have, like acid cleavable linkers, which is true for SG, or protease cleavable linkers, which holds true for TDXD. And the first ADC that we got to know, TDM1, had actually a non-cleavable linker, and that requires a complete degradation of the antibody for the payload to be released, also leading to some amino acid residues being still linked to the payload, and that might have an impact on the activity of the payload. There's a distinction also between a stochastic and site-specific conjugation chemistry, and we are seeing the first ADCs with site-specific conjugation being in the clinic today. None of them, as far as I know, is approved yet, but this is also promising. So in this step from the first to what I call next generation, because I really don't know how to count these generations. I don't know if there is a generation between TDM1 and TDXD and what that would have been. But what has happened was the new linker technology, improved conjugation chemistry, membrane permeable payloads, increasing thereby the therapeutic index by a bystander effect, also leading to a more tissue-agnostic profile. So we see that these ADCs work better in different tumor types, but it comes to at a price, and that's we have 10 to 100-fold increased circulating and conjugated payloads. So we do have some off-target and off-tumor toxicity. So the increase of the therapeutic index is not brought about by actually decreasing toxicity, which was initially the idea of having an ADC like a magic bullet, as Paul Ehrlich some time ago postulated, but it's by increasing dramatically the efficacy. We skip that, and I want to show you some preclinical data because I think this is quite amazing, but it does also relate to the clinical efficacy, and I can show you that as well. And that's basically preclinical comparison between TDM1 and TDXD in different cell line models, expressing different levels of HER2. And you see from left to right that the expression of HER2 does actually decrease. And you can see that TDXD as the next or third generation ADC does work even in cell lines with only a very, very weak HER2 staining, and TDM1 doesn't. And then there's another model which I think is very, very interesting, and that's a co-culture of HER2 positive and HER2 negative cells. The co-culture and the HER2 staining is shown on the left hand. In the middle panel, you see these co-cultures being treated with TDM1, and what you see is really, you just get rid of the HER2 positive cells. And on the right-hand side, you see TDXD, and there the treatment has gotten rid of both HER2 positive and the HER2 negative cells. Does that translate into the clinic? Actually, there has been a very, very interesting study by Otto Metzger-Filo presented a couple of years ago in San Antonio. That's a neoadjuvant study where they prospectively scored heterogeneity of HER2 expression in the Coccan biopsy and compared the non-heterogeneous versus the heterogeneous group of patients who were all treated with TDM1 and additionally also pertuzumab, but just forget about the pertuzumab. What you can really see is that TDM1 was only able to elicit a pathologic complete response in those patients who did not show any sign of heterogeneity, which was prospectively scored and defined. So this is a grouping that was in the primary endpoint of the study, sort of showing you in the clinic what the preclinical models already showed. And one of the things which I found really dramatic are results from Destiny Breast 1. And you see it's actually a talk about SG, and we haven't been talking about it yet. But I think this is just to demonstrate how different these next generation ADCs are from what we started with. And these are patients with HER2 positive metastatic breast cancer, heavily pretreated, and they've all had prior TDM1. And there's a confirmed overall response rate of more than 60%. This is one phase 1 study. There's another one showing exactly the same response rates, and randomized trials, you all know, show exactly the same. So this is tremendous. TDXD works, same target, other payload, next generation ADC, tremendous efficacy. But let's turn to SG, sacituzumab govitecan. What is it? It's a humanized monoclonal antibody against TROP2. That's a cell surface antigen. It's ascribed to aggressive tumor behavior, etc., but that's true for many of these antigens which have a prognostic role. It's humanized, and the payload is SN38, which is the active metabolite of irinotecan. And having said that, you will already guess or already know what the main side effects could be also of SG. It's got a hydrolyzed linker, so some of the payload is even hydrolyzed, released when the ADC is bound to the surface of the cell in the acidic microenvironment of the tumor. So this is already eliciting bystander effect. So it's a potent topoisomerase 1 inhibitor, and it's got a high drug-to-antibody ratio of nearly 8:1. TDM1, for example, has an antibody-drug ratio of 3.5:1. So also this is of importance. Now, why are we so excited about SG? And this is because this was actually the first next generation ADC to really demonstrate tremendous efficacy in the clinic in a randomized phase 3 study, which was called ASCENT. And you can also see it was halted early due to the compelling evidence of efficacy by the IDMC recommendation. And what did ASCENT do? ASCENT randomized patients with metastatic triple-negative breast cancer who had received at least 2 prior lines of chemotherapy. There was no upper limit to that. So these are really heavily pretreated patients, just over 500, and they were randomized 1:1 to receive sacituzumab govitecan 10 milligrams per kg IV on days 1 and 8 of a 21-day cycle versus treatment of physician's choice. I marked in yellow which of the chemotherapies could have been given, and that's eribulin, and that was actually given to most of the patients, vinrabin, gemcitabine, and capecitabine. So in that setting, you can't prescribe which or can't make mandatory which you have to give. You have to allow a choice. And most of the patients received eribulin, which I think probably is one of the best standard of care's chemotherapies. The primary endpoint was PFS. The secondary endpoint was OS and response rate. And the primary endpoint was actually in the brain metastasis negative population. You can also see the stratification factors, geographic region, a number of prior lines. And that's the baseline demographics. I guess you don't see the presentation anymore because I don't see it either. But I'll restart it and I hope I'll be successful. And we'll start from where we have stopped. Can you see that all right again? Okay. You see a median of 4 prior lines of therapy. And for triple-negative breast cancer, this mostly means chemo. And you see the types of chemotherapy that the patients had prior to entering the study. 26% had prior checkpoint inhibitors. So that's mostly all of those eligible based on PD-L1 status. And 8% had a PARP inhibitor. And if you look at the rate of BRCA mutations, that's also those who were eligible to that sort of treatment. So heavily pretreated populations with a modern pre-treatment. And you see the PFS and OS curve on the next slide. That's the final results from ASCO 2022. So not the initial, but it hasn't changed. It just became more robust. And you see that there is an improvement in PFS with a hazard ratio of 0.39 from 1.7 to 5.6 months. So you could also argue giving these patients just basic normal chemotherapy is not working at all. With that, a median PFS, that's just the time to the next scan. And also an improvement in overall survival of almost a doubling from 6.7 to 12.11 months with a hazard ratio below 0.5. And you can also see that at 2 years, there's still a separation of the curves of 17%. So difference which is lasting, and there is a plateau. This is also something that the ESMO magnitude of clinical benefit scale also reflects in the evaluation. Basically, as you see, there is no subgroup that doesn't benefit. If it has increased PFS, obviously it's likely to have a better response rate. That's 35% versus 5%. So a 7-fold increase. And also not more patients responded, but responses were also longer durable. What about the safety profile of that therapy in this heavily pretreated population? And I said it's the active metabolite of irinotecan. As you can see here, It's mainly neutropenia and diarrhea. Okay, so these are the side effects that you should manage prospectively. We prescribe loperamide as standby. We also are quite generous in giving growth factors, but we might be discussing that later. Because you see neutropenia grade 3 and 4, that's more than 60% of the patients. Low rate of febrile neutropenia, okay? And also all grade diarrhea, 60%, 10% grade 3, some nausea and vomiting, but that's manageable with usual care. One measure of how well this is tolerated or well the side effects are manageable really is the numbers of dose reductions. There was no difference between the SG group, 22%, and the treatment physician's choice, 26%, and also treatment discontinuations, and the rates for that were low with 4.7 and 5.4%. So no real difference between these patient study arms. When does it occur? Because I think this is also something that's of importance. If you look at neutropenia and you're mostly interested in grade 3, the lighter, is it blue or is it green? It's something in between. The lighter bar reflects the grade 3 neutropenia for SG. The median time to onset is 21 days. So that's on the first day of the next cycle. The median duration is 6 days. Okay, for diarrhea, onset is also median 19 days until grade 3, and the duration is 5 days. There was no discontinuation based on neutropenia. There were no discontinuation based on diarrhea. How is it managed? Obviously, neutropenia, you have to prevent neutropenic fever. You can give growth factors or dose reduce. You can do the same. You can give loperamide or dose reduce or both for diarrhea. And once you dose reduce, there's always the question, what does it do to the efficacy of the therapy? And that's been looked at in this presentation. And you can see between patients who have been dose reduced and non-dose reduced, and if you focus on the response rate, there is no difference. So the dose reduced patients had a response rate of 47, the patients without a dose reduction of 31. Obviously, patients who had been dose reduced were most likely also longer on therapy, so there might be a time bias, and this is why I think overall response rate is earlier an endpoint than PFS, and this is probably just reflecting some of the reality. And you can safely say that dose reduction doesn't endanger the efficacy of the therapy. So SN38 is metabolized by a liver enzyme called UGT1A1, and there's different genotypes, and one of them, the homozygous STAR28 allele, is actually not really performing its job. So these patients are at higher rates of or higher risk of side effects. And for irinotecan, there's actually a black box warning in the FDA label saying that if you know that this is the genotype, you should definitely start at a lower dose. This is not in the label for SG, so it's also not recommended that you should test. You can also discuss that. This is data from ASCENT, so the study that we've been talking about for the time right now. 14% belong to that group, and you see rate of febrile neutropenia is 18% versus just 3% and 5% in homozygous wild type or heterozygous patients. And there's also a difference, numerical difference in the grade 3 or higher neutropenia. I brought something where we heard that actually for you the approval is still pending, so from Tropics, and we're not looking at the efficacy, but we look at the genotype and data on side effects. We see that there is less patients with the STAR28 homozygous genotype, but we can also see if we look at all grade 3 and higher AEs, that there is like a dose-dependent effect from 67 to 92. Also, this is reflected in the number of dose reductions and discontinuations. So 5 versus 12%. The main difference, again, being here the neutropenia, but also the diarrhea. And there was also some more GCSF given in those patients with a star 28 homozygous genotype. Just to show what we do in the clinic, that's our pre-medication schedule. So we give Akynzeo, which is a fixed combination of ondansetron and netopitant. We give dexamethasone and H1 and H2 blockers to prevent infusion reactions, and we give some paracetamol also. And then we start the infusion of sacituzumab govitecan on day 1 and 8. Different times of infusion rates. And we actually do give primary GCSF prophylaxis on day 2 to 4 with a short-acting GCSF and 9 to 11. There's certainly a lot of dispute about this. Should you do it? Should you not do it? We think this is a therapy that does actually impact patients' lifetime. So we want really that the patients do receive it. And the best way of not having to dose delay or dose reduce is, in our eyes, giving GCSF. Obviously, that's something costly, and you don't have to do it, and you can also wait until the neutropenia recovers, and you can give secondary GCSF prophylaxis or dose reduce. All these options are viable. There's a couple of interesting subgroup analyses. A small cohort was actually treated in the second line. These were patients who rapidly progressed after neoadjuvant on adjuvant therapy. And you can see there is no difference in efficacy if you gave it second line, so if for the rapid progressors after neoadjuvant therapy, or in later lines. And also, some patients did initially not have triple-negative breast cancer, but did have hormone receptor-positive breast cancer. You could argue how many of those had maybe low disease, like 1 to 9%, and maybe they were triple-negative. We don't know this detail, but at least we see even in this subgroup, it does work as well. Now, one of the points that I haven't mentioned yet, it's a targeted therapy, and patients had not been measured for the target when entering the study. There's one good reason, and this is that TROP2 is actually highly expressed in most triple-negative breast cancers. Now, this is a subgroup analysis, exploratory analysis, stratifying patients for TROP2 expression. You see there's 3 groups based on H-score, which is a product of the percentage of stained cells and their intensity. It ranges from 0 to 300. So the highest group is 200 to 300. That's more than half the patients. The middle group is 100 to 200, and there's still 25% of the patients. And still considerable expression in most of the low patients with a score below 100, and that's 20%. And if you compare the response rates on the right-hand side, you see in each of these groups, response rates for SG are always higher than for the standard of care chemotherapy, and that also is true for the PFS. Obviously, this is exploratory, but it doesn't really give any reason to measure the target before putting someone on the drug. So to conclude this, SG for metastatic triple-negative breast cancer significantly improves overall response rate, PFS and OS in heavily pretreated patients, irrespective of hormone receptor status at initial diagnosis of TROP2 expression, and I haven't shown you yet, but I will, HER2 IHC status after PD-L1 therapy, and even in second line for the rapid progressors. Manageable toxicity profile with few discontinuations. We've talked about this. So this clearly is a standard of care for the second line therapy of metastatic triple-negative breast cancer. But are there alternatives? And obviously, because that's also been discussed a lot, there are alternatives, at least for a subgroup of patients called HER2 low. We don't think they're a biologically distinct subgroup, but they are based on this target distinct subgroup because it's druggable. And this option is trastuzumab deruxtecan. Who are those patients who are HER2 low? That's the patient population. which are not IHC3+, but IHC1+ or IHC2+ without gene amplification. And these are called HER2 low. We're not going into the discussion of a subgroup that might be called ultra low, but these are the patients that have been targeted in a clinical study called Destiny Breast 04, which we're going to see. How many are there in the triple negative population? It's about a third of the patients. And I summarized the data from Destiny Breast 04 on just one slide. You see the trial design. So these were patients with, and that's just the triple negative subgroup in that study. And also you can see that's only 58 patients, 1 to 2 randomization. So these are not many patients. They had HER2 low IHC status, 1 to 2 prior lines, so earlier line of therapy, and were then randomized to trastuzumab deruxtecan or treatment of physician's choice, capecitabine, eribulin, gemcitabine, paclitaxel, nab-paclitaxel. You can see the response rates for the hormone receptor negative subgroup on the left-hand lower panel, 50 versus 16%. See also the control group is a bit better. That's an earlier line of therapy. And you can see exploratory analysis of these triple negative patients. There is an improvement in PFS and also of OS. It does have a different safety and side effect profile compared to SG. So there is more GI toxicity, less myelotoxicity. There is some fatigue, and also, and I haven't mentioned that for SG, but for both SG and TDXD, there's also a risk of alopecia, which is of importance to our patients. Now, there's something that I want to point out, which I think is interesting. You have fewer dose reductions with TDXD compared to the control arm, but you have more dose discontinuations for TDXD, twice as many. And these are all due to ILD, and you've also heard about that. And the problem here is that once you have a symptomatic ILD, you need to permanently discontinue the drug. And that's these 8% of the patients. So this is something that you also have to bear in mind. You can also see that during the first 12 months, there's quite a linear increase of cases of ILD. There are some prognostic factors which make ILD more likely, like younger age, lung comorbidities, impaired renal function, not the dose that we're using for breast cancer. You see that's 5.4. I think in lung or gastric cancer is at 6.4, and also a decreased baseline oxygen saturation. So what does the ESMO guidelines say? In second line, and this is the current version, the next line of therapy for the triple negative patients in second line should be SG with an MCBS of 4. But after that, you see, at least for the HER2 low, and that's about a third of the patients, there's trastuzumab deruxtecan also with an MCBS of 4. Why is there a difference in the positioning of the lines second to third? And this is not from the guideline, that's an expert consensus statement led by Paolo Tarantino, addressing this question, and it's basically on the level of evidence. That's only 58 patients with triple negative breast cancer haven't been treated in Destiny Breast 04. So take-home messages. Metastatic triple negative breast cancer is a heterogeneous disease. We didn't talk too much about it. First line treatment selection is based on the identification of predictive biomarkers, BRCA mostly in PD-L1. Sacituzumab govitecan is a standard of care for second-line metastatic triple-negative breast cancer, and it's endorsed by many international guidelines around the globe. ESMO attributes a magnitude of clinical benefit scale of 4, which means there is a substantial improvement. I think looking at the data, this is as good as immunotherapy in terms of increasing overall survival, but treating all patients irrespective of PD-L1 status. So this is accessible to more of the patients. There's no biomarker-based pre-selection, which I think always is quite a pity. And I think I've used up more than the time I was given to talk. So I come to the close and thank you for your attention.
Thank you so much for that lovely presentation, Professor Mame. That was beautifully put, and I definitely have to adopt your quote on the passive smokers and the bystander effect. That was really clever. So this is so interesting, and I could listen to you all evening, but I do have quite a lot of questions that have come in. And well, one of the important questions, I think, is that well, you say that you really don't need a biomarker for the TROP2, but I'm sure you tested your patients in the studies, didn't you?
Yeah.
Yeah.
So we tested that in ASCENT, yeah.
Yeah, and you mentioned something about the response rates being higher in the high-score TROP2 patients, but did you actually see any action at all in the TROP2 0 patients?
So there is the distinction, or the stratification in ASCENT was in these three subgroups. There's also data from the TROPIC study, which elaborated more on the lower end. And even there, I mean, it is like multiple testing and very exploratory. And there's some differences sometimes if you look at PFS or OS, and sometimes it looks like that, or sometimes it looks like that. But even if you look at the really lower end, 0 to 10, which is hardly any TROP2 staining, there still was benefit in terms of OS for the patients who had been given SG compared to chemotherapy in TROPiCS-02. So I think this is why I quite like the TROPiCS-02 data as well in terms of TROP2 expression, because it focuses more on the even lower range and gives you more detail on that. We're also looking in one of the prospective studies in the post-neoadjuvant study, which is completing as we're sitting here, so enrollment. And there, TROP2 is prospectively measured and will be one of the readouts presented very early on after the events have been reached.
Thank you. And I got a very interesting question from the audience about the bystander effect and side effects. So we're actually wondering, is it so that due to the bystander effect, you will have a higher toxicity from the organs affected by metastasis when you give Trodelvy?
That's a very interesting question, which I couldn't really answer based on data. On experience, I wouldn't say that. So the bystander effect. So it's coming back to the picture maybe of passive smoking. It does depend on how close you are, and if you're in an enclosed environment, or if the smoke is carried away by wind. We don't see that really. So the idea would be, if there is liver metastases and you give SG, is there more liver toxicity? No.
No. Okay. Excellent. That's assuring. I was wondering, we talked a little bit about immunotherapy earlier on, and a known problem is that we do sometimes see pseudo-progression. Is that something that we would have to take into consideration when evaluating our patients on Trodelvy?
I have never found a case where I had a suspicion of pseudo progression. Just today, I was talking to a patient. She's on a clinical trial for ovarian cancer with another ADC targeting folate receptor, so mirvetuximab. And she's been on the drug for now 9 months, but is now progressing. And she also asked me, could this be pseudo-progression, because she's young and breeding a lot? Not after such a long therapy, and not with that mode of action. We haven't seen that. And especially if you think, what is your choice? You have these patient population in ASCENT, in the control arm, they had a median PFS of 1.7 months, telling you that if a drug doesn't work in that setting, they will be progressing rapidly. So no, I wouldn't consider that. That would be a really, really rare thing. And I wouldn't start thinking about that in my patients.
Okay,
I mean, there's
great.
always some situations, where you have a dramatic drop but that's very constructed, I think.
Well, one of the reasons why I'm asking is that also you see, like when you do eribulin, if you're tempted to do the imaging too early, you would probably see the patient progressing for a bit before they respond. So what would you say would be the right time to do response evaluation on SG?
So there is no one single time measure that you could give. There's some patients where I say I will restage them even after 2 cycles, because they have such a burden of disease and such a need for remission that I want to change the treatment rapidly if it's not working. Mostly routinely we do every 3 cycles initially, and then might have a longer interval later on if the drug really works over a longer period of time. But usually it's 3 months, 3 cycles, 3 months, somewhere around that.
Right.
But in those which are rapidly progressing, I look earlier.
So I'll ask you the question that nobody wants, and that is, have you seen any signs of this working in untreated brain mets?
Not personally.
Right.
But
so would you recommend then that we treat brain mets up front and then go to SG afterwards?
Usually, yes. I mean, stressing the usual, because there's always the exception. And if you have small brain mets, sometimes you do have things that you think they could be brain mets. The neuroradiologist said, not 100% sure. And then the radiologist or radiotherapist says, we can control that. Then I think this is fair to start therapy, systemic therapy, and reconsider after looking again. But usually, if I would treat the brain mets first and then start. It's always like a balancing on where really is the major disease burden. So if it's really in the distant organs, obviously you start systemic therapy because that's the most important bit. If it's mostly the brain, you will treat, this is a no-brainer, you will treat the brain. The HER2 metastatic ESMO breast cancer guideline did make that some sort of distinction previously for tucatinib and TDXD. Based on that, I think that might also be reconsidered. For TDXD, we see really good data. Now, we've seen that also at ESMO for the HER2 positive, and it's also coming for the HER2 low situation. There's no such systematic evaluation yet for SG. I mean, brain metastases are also far more frequent in HER2 positive. Still, if it's common in triple negative, but not as common in HER2 positive. And they live longer with HER2 positive. So it's quite explainable why there is more data from TDXD in the HER2 positive setting and also in a HER2 low setting. Yeah.
So I think we have time for one last question. And I was curious about the ILD, that you said that about 80% would suffer from ILD. And is it so that this would tend to come early on in the treatment? And would you check for it in any way other than instructing the patient to be aware of it?
So I think this is a very good point, because I was jumping back and forth from SG to TDXD, and then that might have been a bit confusing. There haven't been like these numbers of ILDs seen in SG. So these are single cases. I think most of the studies had none of ILD or just one. And there's not an attribution committee in the SG studies to rule out that it's not something else. So these 8% were the patients that had to discontinue trastuzumab deruxtecan for ILD. And if you look across all the studies with TDXD, you have a rate of 10 to 12%. Higher grades are rare, but you have to stop the drug for a grade 2. And in fact, this is something which is quite difficult because you want to find it before it becomes symptomatic, because that defines grade 2. And this is why initially we run quite frequent scans to look for ILD with TDXT. We don't have to do that for SG. I think this is one of the, I mean, you can't compare the drugs. They're both very good, and we're really glad that we have them. I'm also glad we didn't talk about sequencing. I don't know how TDXT is approved, because sequencing will become a real issue in the future. But they're both there and they're both important. But this is one of the advantages you have with SG. You don't run the risk of having to stop 8% of the patients because of ILD, even despite their benefiting from the drug.
All right, I think it's time to wrap up. The broadcast is coming to an end. Thank you, Silje and Fredrik, for a great presentation and a great discussion afterwards. I think we could have carried on for at least half an hour. There have been several questions coming up, so we have to cut them short, sadly. Thank you, everybody, and to all of you who have tuned in to us, thank you for choosing to spend time with us. We appreciate that very much. This broadcast will also be available as an edited recording in a very short while, and we hope you found the discussion and the presentation enlightening, and that we will help you in your clinical practice when you start to work tomorrow. We wish you a great evening from the studio. Thank you very much.
It's been a pleasure, and good night.
Thank you, guys.
Night.